The ventilatory demand then is your body producing the CO2 and how much you need the movement of air to get rid of that. That's your ventilatory demand. Normally, the supply far exceeds ventilatory demand. The cases where that doesn't happen generally involve significant underlying lung damage. So, we're going to look at causes. There are 4 broad classifications of hypercapnic respiratory failure. And when we talk about hypercapnic, again, we're talking about PCO2. In all fairness, many times, most of the time, respiratory failure involves a little of both. Okay, number 1 is airways and alveoli. You've got things like asthma, emphysema, chronic bronchitis, cystic fibrosis, things that prevent CO2 from getting out of the airways and alveoli. A second group of causes for hypercapnic is central nervous system. Think about a severe head injury that damages the brainstem or causes severe swelling, a drug overdose, a stroke that involves the brainstem, spinal cord injuries, things that prevent the central nervous system from sending the right signals to the lungs to tell it to breathe more. So that would be a second category of hypercapnic respiratory failure. Now, I also want you to think about if your brain is injured and you're not getting the signals to breathe, you're also going to end up with some hypoxic issues. But the hypercapnic issue tends to come first. The third is chest wall abnormalities. Things like flail, chest, fractures, a mechanical constriction, muscle spasm, things that don't allow your chest wall to expand. And then a final category of things that can cause hypercapnic respiratory failure are your neuromuscular conditions, muscular dystrophy, multiple sclerosis, a couple of others would be Guillain-Barré. Guillain-Barré and myasthenia gravis. When those patients get tired, they can lose the ability of their respiratory muscles to do what they need to do. So those are your primary causes of hypercapnic. Now we'll look at hypoxemic respiratory failure. In hypoxemic respiratory failure, the primary problem is oxygenation failure, an inadequate transfer of oxygen between the alveoli and the capillary bed. 2 main concepts here. The PaO2 is at a level that indicates an inadequate oxygen saturation. And the second is in spite of administering oxygen at about 3 times room air. So basically we say a PaO2 of 60 millimeters of mercury or less when the inspired oxygen concentration is 60% or greater. Remember, room air oxygen is 21%. So when we can't get a PaO2 over 60, even though we're giving 60% oxygen, that is a hypoxemic respiratory failure. Same little gas exchange issue, but the problem here is we can't get the oxygen to cross over. So some causes, and we're going to look at these causes individually, but as an overview, VQ abnormalities, that's ventilation perfusion, diffusion limitations, and then alveolar hypoventilation. Alveolar hypoventilation is primarily hypercapnic, but it will cross over. I mean, if I'm not breathing, I'm not going to get oxygen in either. All right, let's talk a little bit about the relationship of ventilation and perfusion in a normal lung. The volume of blood in each minute is about equal to the amount of fresh gas that reaches the alveoli each minute. Okay? So fresh gas to the alveoli is 4 liters, and the amount of blood perfused at your cardiac output is about 5 liters. So your normal VQ ratio is 0.8. Now I do know that your book says 4 to 5 liters for each and gives you a normal ratio of 1. That's all right. But most of the literature that you look at will say that a normal VQ ratio is 0.8. So when VQ is greater than 0.8, when ventilation is more than perfusion, then the VQ ratio will be greater than 0.8. If the VQ ratio is less than 0.8, then there is a mismatch caused by poor ventilation. Okay? So when the VQ is greater than 0.8, you may have a mismatch caused by poor perfusion, and when the VQ is less than 0.8, you have a mismatch caused by poor ventilation. Probably not something you need to memorize, just think of it conceptually. If I have a blood clot, for example, the blood clot in my lung is going to affect perfusion. So my perfusion number goes down. Perfusion is on the bottom, that's the Q. Okay, so ventilation goes up, perfusion goes down. My VQ ratio will go up. By the same token, if I have a huge pneumonia, perfusion is okay, but ventilation goes down, and so then my VQ is less than 0.8. Now what do we want to say that is? Well, it helps if I push the right button now, doesn't it? Well, that's bizarre. Wasn't it working a minute ago? I must have been fiddling with it, not realizing I was fiddling with it. All right, so this picture here demonstrates a range of VQ relationships from shunting to dead space. Okay, an absolute shunt is up here. That's picture A, and that's where you have no ventilation. And you know, the classic example there is fluid-filled alveoli. So if you've got this alveoli filled with fluid, there's no ventilation there, but perfusion is just fine. So that's an absolute shunt. The area is perfused, but no oxygen is crossing the alveolar capillary membrane. Now, there are two kinds of shunts, and you've learned about some shunts when you did pediatric cardiology. Intrapulmonary shunts. This is an intrapulmonary shunt picture here. That's where the shunting occurs within the lung, like pneumonia, atelectasis, asthma, increased secretions in the lung, something that prevents air from getting into the alveolus. In an anatomical shunt, the best examples I can give you are babies with heart defects. They have anatomical shunts where the blood passes through a channel and doesn't go to the lungs. An example would be a VSD, a ventricular septal defect, where the blood goes from the right ventricle to the left ventricle and never goes to the lung. That's an anatomical shunt. When we're talking about VQ relationships in respiratory failure, we're talking about pulmonary shunts. Now in B, you've got partial compromise by secretions in the airway. C, it shows you the normal unit where air moves, perfusion happens. In D, you've got partial clot. So here, in D, the problem is in the circulation piece. And in E, that is called dead space. There is no perfusion to that area. Ventilation is occurring. But what good is ventilation if there is no blood supply there to pick up the oxygen? So no perfusion due to obstruction of a pulmonary capillary. The area is ventilated but not perfused. All right, so what we just talked about was the range of VQ relationships, okay? Now, diffusion limitation is also a form of shunting. Okay? Gas can't get across the alveolar capillary membrane because the membrane is either thickened or destroyed.